Good evening, ladies and gentlemen. I say it's a great honor and pleasure being here with you all, talk about something we propose new, especially to how to manage your soft losses in healthcare settings. And before that, I understand I'm supposed to give myself a little bit introduction. So, but for the time's sake, I'm not going to read it. So while you're reading it, I'll just say a few words. I'm Jack Liu, and I'm the founder and the Chief Quality Officer at Yanch Medical Consulting and Services. The rest, you can read them all by yourself. So I'm going to talk about the translation of soft losses into soft assets, which supposedly is a new practice we propose in healthcare financial management. The reason I say we propose is because it hasn't been done this way ever before, and specifically with the invisible, non-measurable financial losses. I call them soft losses. And I believe it is with a very unique importance to hear whoever is currently running a hospital or a healthcare organization or plan to run or plan to invest into such an organization. You might be very interested in doing this. And so it doesn't matter whichever phases we are in. I believe there's one common goal we share dearly. That is, you want to run a healthcare organization with measurable financial successes. So before we start, let me just give you a picture of the healthcare spendings in the US annually. And you can see those, okay, it doesn't work on this, I'm sorry. So just forget about this. This does not work on the monitor. So figures in brown color actually are the spendings in health care within the United States from different years. Oops. Okay, then you noticed those numbers were from CMS. And what is CMS? I believe some of you know, some of you, especially the ones who does not work in healthcare setting, healthcare health sectors in the States. And I will just take this opportunity to say CMS is an abbreviation for Centers for Medicare and Medicaid Services, which is an agency for care delivery, and also is the agency for operating systems in the US within healthcare sectors. And more importantly, it is in charge of translating policies into financial signals with the healthcare setting. In other words, they are very powerful governmental agencies in the entire healthcare sectors within the US. And again, those were the categories used by CMS. Those categories were tell you about 6, 7 different categories where those wasteful spending go. In other words, where the money lost. So again, those brown color figures is a wasteful spending, and according to their category. And you can see those numbers are quite scary, big numbers. And this is just a tabulation of those figures. So in 2019, someone with the name William Schwentz published his great research work. And he put all those wasteful spending together against the total spending in the US in healthcare, and come up with this very easy to understand results. 25% spending is lost to poor management of quality. And this publication becomes an instant hit. It has become the most popularly, widely cited references over 100 times by different authors. And the articles in the black were just a few examples of those citations for different publications. Now, I would like to direct your attention to the brown colors. According to the research, 25% of the spending is lost, translating into absolute number. This is the number we could save if we managed somehow to eliminate those wasteful spendings. So maybe at a nicer level, as we presented before, it's a little bit hard to digest. So let's just take one single hospital with an average size 300 bed in the US, which is a popular size. Okay, then those numbers were actually for 300 bed size hospitals annual spendings, according to their scope of practice. Some hospitals practice more, offers more services, so it goes higher on spending. Some less, goes lower. And so let's say we're not so fortunate enough to eliminate those entire 25%. Let's say we do something, we could at least save half of that 25%. That is 12.5%. Still, is from 6 million to 125 million per year per hospital. That's how much money we could save. Then next, I want to review with you together the principles, the major principles we use to run nowadays a healthcare organization, which is called value-driven, patient-centered, evidence-based, and outcome-focused practice. But even though we're doing this, we still somehow lose 25%. So that means the current principles are not enough in terms to help us eliminating those spendings. So that's why I propose at the bottom, quality should be added to the existing principles as a core principle. Why? Because from previous slides, you'll see those laws, those categories, it's just fall right into healthcare quality and safety domain. So I'm going to share two cases with you, happened in New York City years ago. And one is clinical, another is non-clinical. But please be advised, those information is for only the sole purpose of learning and improving, and shall not be used against any hospital, any organization, in case you know that case, those two cases. According to US PSQIA, Patient Safety and Quality Improvement Act from 2005, those things, whatever you grew up, is not working, because in other words, it's protected for the purpose of improving. So case number one is the elevator in the hospital. And because of the financial restraint, whatever reason, is due for maintenance services, but the leadership decided not to go for this time. So soon after that decision was made, one day, a little obese patient somehow managed to stop her leg between the gaps, in the gaps between elevator and the floor due to the misalignment of the floor and elevator. And during the struggle, tried to pull her legs out, elevator started moving and severed her leg. So you can imagine what followed that incident, legally and financially. The second case is a clinical case. It's a patient who suffers severe chest pain, was brought into OR for emergency aortic dissection repair after a CT scan. So after the sternotomy, after opening up the the pericardium and exposed the heart, and performing surgeon did visual examination and also used ultrasound to see if there is any hidden aorta dissection, which they found none. So then the chest was closed, the patient was put back to ICU. Then early next morning, patient expired in the bathroom within the ICU. The problem even worse is somehow they didn't report this unexpected death within 24 hours, which is the requirement from the state regulatory agency. So this one case brought two folds of impact, negative impacts to them. And you can imagine what's going to be, how much it's going to cost them, not only monetary wise and the reputation damage and all those following events. So among this great audience here, I believe you have great expertise in finance, and especially at various different healthcare settings. And I believe your understanding of finance in healthcare is way better than mine. But however, because of the difference, so I'm not going to focus on the financial aspect. I'm going to focus on the losses that is invisible, non-measurable, not shown up on your balance sheet, which your CEO and your CFO look at it almost every single day. And so, what are we going to do? Why would this would happen? Because the current system we use does not pick up those signals. And those losses, on the other hand, is more qualitative other than quantitative. So it's hard for the system, the financial system in our case, to pick it up. So, in other words, if we do not somehow manage to turn those non-quantifiable, non-measurable indicators results into measurable metrics, then they're going to just skip. We don't even see them. We just keep losing money. So we somehow need to find a way to deal with it. But again, the way we propose is also come from healthcare quality and safety domain, because as I mentioned before, all those losses, all those indicators actually is within healthcare quality and safety domain. So just to give you one example how difficult it is for the current financial system within healthcare industry to pick up those things. Let's say reputation damage, how you value it. It does not, you don't see the effect till years later, till things going down little by little. How can you evaluate this reputation damage? So that brings us to, we have to find a way to somehow make them monetizable. That's the word financial experts know it. So on the slide, that's the reality we're dealing with. We're dealing with all the good things. They're all good, they all work, but somehow we're missing one major part, which is the quality and safety. And at the present time, in the realm of healthcare, the inconvenient truth I read it here in financial system is the system we're using is not designed to capture and focus on those losses. They are focused on the values or items with clear downside legs to them. So that's a situation we're facing. And furthermore, the current practice does not really have any effective or active way of dealing with soft losses, the soft losses. Because the way we deal with soft losses more passive, reactive, not proactive. So we're dealing with losses already incurred, but we're not anticipating to deal with the losses that will happen. So that's the situation we are facing. So now we should ask ourselves a question, can we improve it or change it? So the answer is yes, we can. But before we start our quest to begin change or improve, we need to remind ourselves of one fundamental concept, which is improvement or change can only be done on things that is measurable, or in other words, can be measured. Otherwise, we don't know if we improve it or not. Improve it or not, we don't know. You have to measure it somehow. So since we work with non-measurable indicators, then we need to invent a way, like I mentioned before, to make them measurable. So on the slides are the few examples of principles we propose to make such metrics. We call proxy metrics. So for the sake of time, I will not go into technical details on how to make those results measurable with a clear dollar sign. If anyone here is interested, let me know. We can have a further discussion afterwards. So we're proposing translating soft losses into soft assets. So what is the meaning of the translation? Well, research shows 25% of healthcare spending is lost due to poor quality. So let's just think in, also remember those two cases that I just gave you. 25% is a huge loss to any organization in that matter. 25% is a huge hemorrhage for your well-being of your organization. So what we can do, of course, action has to be started now to correct it, because only will show the effect over time. So if you start strategizing your soft losses into organizational level strategies, policies, then you actually are beginning to starting the process of translating soft losses into soft assets. And the outcome will be visible and quantifiable. Then you will say, now how can I see the soft losses, soft assets? Well, what soft assets we're trying to translate into it? So in addition to what's outlined on the slide here. Generally speaking, if you reduce non-quantifiable losses like trust erosion, clinician disengagement, and reputational decay, and so on, you're not only preventing harms to our patient, but also you are capitalizing the latent organizational value. And you're converting invisible leakage or invisible losses into durable operating capacity. So please remember, those were actually unpriced assets with priced consequences. That's why we call them soft assets. So let me conclude this presentation with a very optimistic outlook. And that is organizations that recognize the importance of turning soft losses into soft assets and redesign their governance accordingly. Will be the ones positioned not only to survive, but also to lead in the next decades of healthcare transformation. With that, I thank you very much for your time.